for this talk. I'm Dr. Muhammad Ramzan and working as consultant interventional radiologist in PKLI. The theme of this talk is to introduce the role of intervention radiology in health system actually, because the family physician are the backbone of any health system, and the major referral is from the family physicians. So my target is just to let you know what we can offer actually in terms of you can say minimally invasive treatment options for so this is my life journey. I have been to many places in the country and outside the country. And what's interventional radiology? The diagnostic everybody knows, but the interventional radiology is a therapeutic branch where we offer minimally invasive treatments. There are no incisions, there are no scars, in most of the cases, no hospital admission, and you can see the skin incisions are sometimes even less than few millimeters actually, and most of the procedures are done under local anesthesia, and it's a same day case procedures. You don't need to admit the patient. You don't need scalpels. It's not really very invasive. So look at this patient is a patient of trauma with large pseudoaneurysm, and this thing was done, like the stenting was done percutaneously, so minimal invasion but maximum results. I'll just go through the list of procedures what we can do actually. We can do aortic aneurysm, peripheral vascular disease, especially in diabetic patients. We do cancer treatments, we do fibroid and adenomyosis embolizations, we open the blocked kidney and biliary system, we do diversions, we do venous interventions like DVT and chronic vein occlusion, especially in lower limbs, varicose veins, we treat AV malformation, with neurointervention as another subject actually as a whole. We do chest intervention like pulmonary embolism and you can say the pulmonary AVMs and this kind of stuff. We do MSK and pain management. In MSK I'll go through in future in the next slides actually, and infertility I will describe in next slides, dialysis access, biopsies, drainages, GI intervention, and thyroid and breast interventions we offer. We do EVARs for abdominal aortic aneurysm, TVARs for thoracic aortic, FEVAR where the complex aortic aneurysm, and we have to stent the visceral arteries like SMA, celiac axis. We do iliac stenting and angioplasties, SFA and Bologna angioplasty, especially in diabetic patients. Every patient don't need the amputation. It's a limb salvage thing we do. This is one of the case. सॉरी यार क्या हो रहा है सॉरी ये कोई टेक्निकल इश्यूज चल रहे हैं स्किप करें इसका एक्सपायर हो गया ये वाला ना इस पे चला दें अपने पे चला दें सॉरी जी ये टेक्निकल ग्लिचेस हैं. तो if you look at this, the left subclavian artery occlusion actually, and you see steel phenomena in these patients, and here we went in and we put a stent in the left subclavian artery for the occlusion, and it's fine now. This is another case where there is you can say common iliac stenosis, and we put the bilateral common iliac stents actually. These are called kissing stents for the peripheral vascular disease. This is a case of SFA occlusion and lower limb ischemia, claudication, and ulcers, and this was the post-stenting. It's a nice, good vessel. This is another case where the SFA was almost completely occluded, and we went in and we opened the whole thing. It's for the peripheral vascular disease. We do visceral arteries like renal artery stenting, especially in patients with fibromuscular dysplasias and atherosclerotic, where the patient is taking antihypertensive and is not responding. So we can do stenting in these cases. We can do SMA stenting and celiac artery. If there is stenosis, we can do post-liver and kidney transplant artery stenosis stenting. This is a case of renal artery stenosis. You can see it's really narrow here on this side, and there's a bit of narrowing on the other side. On next slide, we went in, and you can see this is how it looks after stenting. HPB intervention is the major thing which we do here at PKLI. So we do chemoembolization of the tumors, we do radioembolization of the tumor, we do ablations like microwave, RFA, we do transjugular biopsies where the patient's clotting is deranged. We do, you can say these are the procedure done in portal hypertension to divert the flow and stop the bleeding. We do PTC drainages, we do PTC biopsies, and we treat the post-transplant complication like narrowing at the anastomosis side. This is one of the case where you can see, this is the angiogram of liver vessels, and you can see there's something abnormal here. I don't know if you can appreciate, we put some chemo drug over here, and in the next image, if you can see, we did the angiogram, and this tumor is completely devascularized. This is a post-test case actually. We do, as I said, ablations in both renal and liver tumors. So this is the list of ablations we normally do. There's a bit of difference, but I will not go through everything. So I'll show you another case. This is the liver lesion. If you can see here, this enhancing lesion over here. This is the RFA probe, and this you can see the lesion on ultrasound actually. And if you look at, this is the post-ablation CT, so the lesion is almost completely gone, so it's completely treated lesion. So you don't need to open for every cancer. This is the pinhole surgery actually, or whatever you say. Where the tumors are big in the liver, we sometimes offer portal vein and hepatic vein embolization just to make sure, to increase the volume of the liver, so the surgeon can go and resect the lobe and the tumor so here we did the same thing, actually went in percutaneously into the portal vein, we embolized the portal vein. This is the hepatic vein, we put the plugs and embolized the hepatic vein as well. And this is how it looked like on post-embolization. You can see the stuff here, which is occluding the venous channels actually. So it diverts the flow to the other side and increases the volume of the remaining liver. We also treat benign conditions like hemangioma. Sometimes the patient present with pain and this kind of stuff in big hemangiomas. So you don't need to go for surgery. We embolize these hemangiomas, and they respond very well to the embolization. It's a day case. Patient can go home on the same day actually. So we can do the tips, as I mentioned, this is one of the diagram where we can create a channel between hepatic vein and the portal vein just to divert the portal flow and stop bleeding. This is one of the case of post-transplant liver where the portal vein stenosis at the site of anastomosis. We went in percutaneously and we did the angioplasty here. And this you can see the post-angioplasty image. It's a nice, beautiful portal vein actually. This is one of the post-pancreatic transplant patient where the venous outflow was occluded with a clot and we put a stent in actually. So because of this there was a pancreatitis and it was resolved after stenting. Biliary obstruction, we can cross percutaneously because this thing is obstructed here and we can put a stent in, and if you can see there's a stent at the bottom actually. We can put T-stents in case of, you can say, the hyaloid tumors. So here, if you can see, these are two wires here, and one is going down. So we put one stent here like this way, and the other stent down like this way. So we can take percutaneous biopsy, and this is the biopsy forceps. We can take where there's tumor can't be biopsied percutaneously. We can do through the PTC actually for the diagnosis. In the genitourinary system, we can offer renal tumor ablations, we can do nephrostomies, we can give the PCNL access to the urologist in difficult cases, we can do prostate artery embolization, we ablate large renal tumors, we embolize the angiomyolipomas, varicocele embolization, fibroid embolization, and fallopian tube recanalization are the procedure. This is one of the case of having, you can say, the tumor at the upper pole of the kidney, and there is another tumor in the interpolar area. Patient had single kidney, and there is no option to go for surgery here. So we went in, put a needle here, you can see this is the top tumor, this is the mid-pole tumor. And we burned the tumor, both the tumors are nicely burned on this image. So central tumors, cryoablation that was microwave ablation, and then is the cryoablation is another way we ablate, and this is one of the central tumor which we did cryoablation. Cryoablation can ablate the bigger tumors up to even 7 centimeters in the kidneys. So the needles are placed in, this is one of the angiogram here, and this is how the patient is, and this is the ablation thing, and this is the post-ablation CT you can see, and this is the ultrasound here. So it was completely ablated. This is a case of angiomyolipoma where we went in, and these angiomyolipoma has the tendency to bleed when they are more than 4 or 5 centimeters. So either you have to take it out or embolize it. And the best way is the embolization, because it's a minimally invasive. You can send the patient home same day or next day. So this the tumor, you can see it, it's tumor vascularity, and this the post embolization. Everything is gone here, and the normal kidney is saved here. Prostate artery embolization and another fancy procedure. You don't need to go for a TURP in every case. We can offer, and the results are exactly similar to the surgery, more than 80% symptomatic relief. In patients with the prostate, you can say the hypertrophy symptoms, we offer the patient as a day case procedure. We go in, there's no incision. The main thing is it's a preserved sexual functions, there's no retrograde ejaculation, no urethral stricture, and symptomatic improvement is 80% actually. So the patient is coming in as a day case, we perform the procedure, and we can send the patient back home on the same day on a like antibiotics. So here is the case. We did the DSA, this is the fancy thing, we do cone beam CT, and you can make sure that you are at the exact site where you are embolizing, and this is the prostate one side where we embolize the patient, the prostatic artery actually. Obstructed kidney, as I said, we can put the nephrostomy tubes, we can put stents from the top where the urologist can't go from the below due to strictures, masses or anything. Varicocele embolization is also a nice procedure, a day case, and patient can come and go in a couple of hours after the procedure. Here you can see we're coming from the neck, this is the left renal vein, we're going into the left gonadal vein actually, and you can see these are the coils put in. Fibroid embolization is another procedure which we offer, and it's really good results, especially in patients with menorrhagia and pressure symptoms. Uterus is preserved here. It's a one-day hospital stay, and young patients where there are multiple fibroids, we can't offer anything apart from hysterectomy. We can offer fibroid embolization, and there are patients with those had successful, you can say, the pregnancy after fibroid embolization. So you can preserve the family, you can preserve everything in these cases. ये बाद में बता दूंगा मैं. Around 250 है इसमें PKLI में. This is the typical fibroid you see on angiogram, and this you can see how it's completely embolized. Keep in mind, when we are embolizing the fibroids, there is no harm to the normal myometrium. It's the only fibroid that goes down actually. Dialysis access and AV fistulas are another thing which we can offer. Fistuloplasties. There's a new thing coming in, percutaneous AV fistulas. We can do like with the needles and some you can say the equipments that patient can come. It's under local anesthesia. Again, this procedure is like daycare. Patient is coming, we do the procedure, can go home in a couple of hours, and the maturation rate and the complications are very low because we are not doing anastomosis. We are just creating a channel actually, because in fistulas usually there is a stenosis at the anastomosis actually, and that's the very common thing. These are a few pictures. You can see the dialysis catheter on the left side is in this, the one of the fistuloplasty. You can see narrowing here, and this nicely open here. This is the equipment we use for percutaneous fistula creation, and then you can see this the fistula created, and we sometimes embolize the extra out, you can say the venous drainages to avoid the steel phenomena, so the main vessels can mature actually. So it's a day case thing actually. We control bleeding in emergency situation in most of the cases, like in trauma, GI bleed, hemoptysis in bronchitis patient, post-trauma thing. PPH is another where you find the patients with placenta previa and there is a severe hemorrhage. In these patients, we offer, it's a life-saving procedure. We offer putting the balloon in the both internal iliac arteries, so we can occlude the arteries and the surgeons can do his job, whatever he is doing, and then we can deflate the balloon and we can save even the uterus in such cases and the life of baby and mother. So we can treat even smaller vessels, we can embolize, we do use particles, coils, and this kind of stuff to block the arteries. This is one of the example where you can see the stent is in place in CBD and there's a bit of bleeding here. This is the bleeding you can see very well on CT, and this is the one of the coronal reformats. You can see bleeding at the bottom of the stent. We went in, and this is the bleeding site here. Went in, put a coil in, this is the coil which embolized the thing, and that bleeding was stopped actually. This is one of the lower GI bleed we embolize actually with the coils. This is the post-trauma patient where the common iliac artery, external iliac artery has a pseudoaneurysm. We put a stent in, and it was like stop the bleeding actually. We even do gastroesophageal and colonic stentings, and as I have shown you, we also do GI bleed embolization and PEG tube insertion, especially in head and neck cancer patients. Where they can't do endoscopically, we do it percutaneously under imaging guidance. We do duodenal stenting. This is one of the case where there was an obstruction in the CBD actually. We put a CBD stent, but there was an obstruction to the duodenum. That's the third part of duodenum, third and fourth part of duodenum. We went in from the same access, and we managed to put the duodenal stent here. Keep in mind, these are palliative procedure to make the life easy, where we can't offer any surgical management. We treat varicose veins without scars. It's just the needle we use to prick. We do DVT thrombolysis. The long-term results of, you can say, the venous thrombolysis are not that great. So we do put the catheters in, we put the actylase, and we thrombolyze angioplasty and stent, especially May 3rd, where the left iliac vein is compressed. PTS is the post-DVT when the veins are occluded. The patients had really bad venous claudication and ulcers, and it's really hard. We also put IVC filter for, you can say, to avoid the pulmonary embolism, and we also do SVC stenting where there is a, you can say, superior vena cava obstruction syndrome that can relieve the symptoms. This is one of the case where we did actually the iliac vein stenting on this side. So there was a bit of narrowing, there was a clot, we cleared the clot and we put a stent in the left side. It was May 3rd kind of thing. This is the IVC filter insertion, you can see here. We treat high flow AVMs and venous malformations like embolization and sclerotherapy. So this is one of the case where there was a big uterine AV malformation. It was supplied from both sides. So I just put one side here. So we were there. We put this my catheter in. We put the glue in, and if you look at the end, nothing was seen. And this patient, you can say, treated with one session only. AVM sometimes needs more sessions actually. This is a case where there is an AV malformation within the kidney, and this was embolized using coils successfully, so you don't need to take the kidney out. This was pelvic AVM. It was huge actually, and if you look at, this is the outflow of this AVM actually. So the vein was really big actually, so it came in from the arterial side. In this case, actually, we embolized the outflow first, and then we came here, and then we embolized. This is the AVM, which the nidus of the AVM, actually. We also do lymphatic, you can say, the interventions, where there is a chyle leak, actually, and when the chyle is leaking, the patient is losing a lot of protein, actually. So repeated effusions, repeated ascites. So this is one of the case. We went into the cisterna cali and went up, and this is the duct, thoracic duct, and we embolized this thing actually over here. So we can treat the pulmonary embolism, we can do thrombolysis, we can do mechanical thrombectomy in patients where the pulmonary embolism is causing the right heart failure. We treat the pulmonary artery AVMs and aneurysms, bronchial artery embolization and hemoptysis, and we can also do bronchial or tracheal artery stenting. These are palliative procedures where the tumor is compressing these structures. So this is one of the case of pulmonary AVM. We went in. This is the super selective. My catheter is here, just there. So we put a plug in and there is nothing here, it's all gone now. You can see this, the plug here, which how we embolize it. So head and neck, we can offer carotid artery stenting, cerebral AVM, and carotid cavernous fistula embolization, aneurysm coiling. This is inferior petrosal sinus venous sampling. We can do dural sinus venoplasty, especially in dural sinus hypertension. When there is a narrowing, we can treat AVM, neck AVMs. We can do parathyroid venous sampling. We do thyroid venous sampling. We also do thyroid, benign thyroid lesions, you can say the RFA, and we can offer embolization of goiter in patients where the goiter is causing symptoms and they can't do surgery due to multiple, you can say, the comorbidities and the risks of general anesthesia. Here the results are again good to shrink the size of the goiter and make the life easy for the patient. So this is one of the, actually both the things are over each other. So you can see this the right adrenal and this the left adrenal. We did sampling here. So it's a bit of technical. This the inferior petrosal sinus. You can see this is my catheter on this side, this on this side here. And this is what's called the around the sella actually. So this is the inferior petrosal sinus. We take samples from here just to see the ACTH production, which side is producing. This is one of the case of carotid artery stenting. You can see here it's nicely done. We do CT guided and ultrasound guided FNACs, biopsies, drainage placements. We do truss biopsies for the rectal cancers. We offer joint injection, nerve block, celiac axis block, especially in cases of chronic pancreatitis and upper abdominal malignancies, pelvic malignancy. We do hypogastric blocks. Ozone treatment is, I think, well known. We also offer pain management in osteoarthritis. This is the genicular artery embolization, especially in chronic knee pain where the medical management fails actually. We can offer the embolization of genicular artery and the results are really good. Lines, PICC line, Hickman line, and portacath insertion for cancer treatments. We offer bariatric embolization. That's the left gastric embolization, left gastric artery embolization for weight loss, splenic embolization for hypersplenism, splenic trauma. We do endometrioma and cyst sclerotherapy. We do pair procedure for the hydrated cyst as well. This is the nice procedure. We put a drain in, take everything out, and put the hypertonic saline. We do sometime in difficult cases where the conventional treatments are not responding, we do superior rectal artery embolization in cases of hemorrhoid, but it's not a regular treatment. It's for the patients where they are not responding to the conventional treatments. We can offer even the superior rectal artery embolization, and the results even here are good. So this is the long list. If you go through every procedure, you can spend the whole day, but it's the list. And my target was just to let you know that we are offering all these procedures at our site, and you are the primary referral. Thank you very much.